All right, everybody, welcome back to New York. Since June, early June, we haven't seen you. We're thrilled to be back here to show you another case of a peripheral intervention as part of the ongoing MedStream 360, which we're very proud to be part of and support. So we have a wonderful case here that we're going to present. We put it together today, so unfortunately, I don't think we have any slides or anything, right?
But I can present
We
the
have some
case.
slides, but we can definitely present it. And it's a case that I think it's a very exemplary case that we can do a lot of teaching from. So introducing my team, to my left is our fellow graduating fellow in his final day, Dr. Ibrahim Ali. To my right is Ken Lee, our wonderful tech, who's been very supportive of us throughout the day today. And then we've got Elizabeth, who's our nurse extraordinaire. So we've got a wonderful case. So we had 1 hour to do it. So we're going to have Ibrahim present the case, and we'll go over the angio, and we'll get started.
All right, so today we're taking care of a 66-year-old male. He has a medical history of hypertension. He's a former smoker and hyperlipidemia and insulin-dependent diabetes. He actually had a STEMI in 2022, had a couple stents put in the RCA, and then had a couple stage PCIs to the LAD. He does have a severely reduced ejection fraction. But otherwise has normal kidney function. He presented to us with bilateral lower extremity claudication, and because of his cardiac disease, we ended up treating him medically for quite some time. ABIs when we first met him were zero point 0.5 and zero point 0.6. And we did an arterial duplex, which showed a elevated peak systolic velocity in the mid-right SFA with a peak systolic velocity of over 300. Distal to that, he had reduced systolic velocity, and in the tibials, in the AT and the PT, had absent Dopplers. So
So he's obviously optimally medically managed, and you saw the iliac pictures. There's nothing going on in the SFA. You've got a moderate to severe calcified SFA with very, very poor flow. It's not really because of his heart failure. You can see that the distal vessel actually fills prior to the flow in the SFA coming down, which is going to be part of our algorithm on what we're going to do. So you can see again, I'm going to let it run. Profundo fills quite briskly. However, you can see the SFA flow is very, very poor. You got a large genicular collateral filling the distal popliteal, and then you can see here that you do have a 2.5 vessel runoff with a very significant osteal tibioperoneal trunk lesion with an occluded, anterior tibial artery. And then down into the foot, you can see that obviously he's got a peroneal artery that's open, and then he's got, and then you can see the dorsalis pedis comes back, and then you can see obviously you have a good posterior tibial artery. So our plan today is to go ahead and intervene on this, and we'll talk about our choices. You can see there's some good close-up pictures that Dr. Ibrahim took, Dr. Ali took. You can see you get the tight mid SFA with the 300 plus velocity, and you've got a distal occlusion right around the C of the CSI tape. And you can see here's another shot of the occlusion. You can see that there's a slight beak with a large the genicular collateral, as you see, at the level of the popliteal. So we're going to go ahead and cross this now. So we chose an 014 wire to go ahead and cross. I'm just going to go ahead and put a roadmap up to give you some, some, don't move. Okay. Just going to put a little roadmap up just to show you the flow. And then you can see the flow is very poor. You can see the occlusion, like I said, short segment, but that's not the reason why I'm demonstrating the case. We have quite a few things to talk about. So you can see Dr. Ali's chosen what we call as an 014 wire, called a command wire to probe. And you can see that the command wire looks like it's not even occluded, probably a very tight stenosis, and has crossed miraculously, which we knew would, that's the lesion. Okay, another lesion distally. And again, you can see here, he's going to have to track the catheter down. We've got a support catheter. Unlike the coronaries here, we use 035 systems because we want to save money. This is a 100 or less than that $40 catheter called the Aqua Tempo. And then we're going to go ahead here and get that close to give him some support to be able to cross this lesion. He's going to have to get into that lesion here to be able to cross. So you can see here, he's going to pop into that area. He's going to give himself some good support. And then once he's there, he should just pop through with this wire. Likely, let's see whether it goes. Took it a little too close. I probably wouldn't have gone that close because you want the wire to actually work. And here it looks like this is the occluded segment. So at this stage, he's going to play for a little while, and then before he dissects, maybe we'll just switch off to another wire here. Give us a confianza wire. Let's do with the coronary wire here. Short segment occlusion. I think the hydrophilic nature of this wire, the lack of tip load, is causing it to not quite function the way we want it to. So we're gonna get the, maybe you can get the catheter a little bit closer here, and then maybe it'll pop through. So we've opened up a high tip load wire like the Confianza Pro, which I'm sure all of our coronary colleagues have been demonstrating. This is a 300, Henley. Uh, yeah. So I think it's very important. I think we'll stop there and we go with the Confianza. So obviously I asked for a 300 wire because all of our endovascular cases require a wire with in order to be exchanging for the next catheter and devices that we're going to have to do. So the same tip load was a 14-gram tip load, right, Ibrahim?
12.
12 gram. Okay, 12 gram tip load here. And obviously we have much higher tip gram wires that we need, but this seems to do the job in most of the cases. So at this stage, our plan is going to be to try to cross this, do an intravascular ultrasound, and then decide our therapy, and then we'll take it from there. So just making a friendly tip, not too violent and not too not violent. So I'm going to give this to him, and then we're going to go. Okay. So once we cross, the idea would be to put, so the flow in the vessel is something that we're not comfortable with, and the reason I pointed out to you the profunder filling before the SFA, and then you saw how slow the flow in the SFA was, shows that in our mind that there will be some sort of layered thrombus in this, and with such poor runoff, our idea would be to aspirate the thrombus out prior to us doing any sort of intervention. So we're going to try to cross here, and likely we're going to cross without a problem. As you see, the tip gram load wire really kind of seems to go and find the channel that we want to find. I'm just going to go to another view to show Dr. Ibrahim where we are. Watching these.
Mm-hmm.
Okay. So creatinine is normal, but even then we don't want to give too much dye, as everybody knows. So we're heading okay. I should be able to find the lumen. Let's see. So we're going to just hopefully find the lumen in a second. And we have found the lumen, as you can see. Looks like we have. No,
Mm-mm.
maybe not. Some of these short occlusions can be tricky in the sense that, this seems to be maybe sliding on top of the vessel. So in this kind of situation, let's see how it goes. You don't want to extend the dissection plane too far down and too far past this. Does it feel real or no? It feels pretty good, right? Or no,
No.
it's not behaving. So pull back, redirect. So we're going to pull back, redirect the catheter to another plane, and we'll try to go. So you're too far up now,
Mm-hmm.
obviously. There you go. Good. Good. So that's going to be part of the issue with these wires, is that in this large vessels, like a 7 millimeter vessel, this may be an issue in terms of directing the wire where you want it to go with these small wires. There you go. It's a better plane. I do like that plane a lot better. Get your catheter closer. Oh, still wanting to go off. So this is, if you look at the C-top classification, which is the classification of occluded tips, this is a convex tip, distal tip. So therefore, this is going to be more difficult to get, to be able to cross, because it'll tend to slide off the convexity of the tip and then of the distal reconstitution segment, and will tend to go off to the side exactly as it's happening. So as he tries a couple more times, we'll probably decide to go with a tip load wire like a Shadow 21. Let me give it a whirl.
Mm-hmm.
So we'll try it with a 21, and then we'll try what to do next. So let me just pull this back here. So we're just going to come back and try to find another lumen here. It's all about trying to find planes and figuring out which plane is going to work here. So the question is which plane works. So I like this a little bit better. I just found a better plane. Push it down a little bit.
Mm-hmm.
The catheter is going down. See where, yep, keep coming. So the catheter comes down a little bit. Okay. I can't quite see the catheter here, so okay, come down with the catheter. Uh-huh. The short segment, and sometimes they behave weird, obviously.
The wire is starting to.
Yeah, and the wire's starting to unravel. So we'll just pull this back. Henley, give me the, there it is. Nope, it did not cross. Huh? No, you don't have the 20? Okay. Give me just a glide wire then.
Stiff angle?
Huh? Not till we get through this lesion. I think once we get through this lesion, intravascular ultrasound would be useful to see where we are. But I think we need to get through this lesion. You can see a very fibrotic lesion, long-standing lesion, causing all these problems. So there's our reconstitution Jones short segment. Should be a jippy, but always never that way when you need it to be. So we don't have the 20, huh? Did they give me a Connect 250T? Okay, so we may upgrade to an 018 wire if this doesn't fly through. We'll see if it does. So we got an 035 glide wire here. The idea of not going with the glide for us initially is because of the fact that I need to torque around this. Because of the fact that we don't want to extend the dissection plane too far distal. The popliteal is a robust vessel, and these wires tend to dissect. And because of that, it's probably we're trying not to go with the glide initially. I mean, a lot of people will say, "Oh, just push a glide through," and so on and so forth. But that's our logic, not to push the glide through. I think we're just trying not to create a dissection plane. It is very. Yeah, I'm just reshaping the tip over here on this side, just to see how it behaves. That we don't have a Connect 250T either. It looks like. So, and sometimes these vessels are very difficult to deal with. So we're going to pull back again. Uh-huh. Because of the flow, there's thrombus in this because I think the flow of the vessel is not very good. And because of that, you have stagnation. I think that's why we have thrombus in this. Let me see. That's why we probably will have thrombus in this. Okay, catheter down now. I can do it. Don't worry. So what I'm doing is just getting a quick loop and just doing a loop reentry technique since it doesn't seem to want to work in any other direction here. So there's my loop. So you can see how fibrotic this is. The loop is not even cracking the vessel. All right, give me the start of 3. So we don't have any wires. I can give you the start of 30 here. But no other wires. None of the other wires I asked for. Give me a straight glide here, guys. There it goes. For guide wire advancement? This is 3D reconstruction software? Not that I'm aware of. The 250T down there. The 250T in the book. Okay. What's that, right? So we just crossed the lesion. Show me down now. So we just crossed the lesion. You can see we're in the lesion. We're across the lesion now. So now I'm going to just go ahead and what we're planning on doing is putting a filter down so it can have a filter. The reason, again, we're using a filter is our vessel runoff is very, very poor because we have a perineal lesion. And we also have this slow flow in the vessel. So I'm just going to go ahead and take this wire, which is the 18 the bare wire, which is the wire that comes with Abbott. When you put this wire in, you have to be very careful because you want to make sure that the tiger side of the wire, there's one side of the wire that has the tiger stripes. That's the one that's distal, because the proximal part of the wire, which is shape, is the wire that has a little golden, I would say, nugget on it that prevents the filter from migrating. The beauty of this wire is that the migration of the filter is independent of the wire, meaning I should say its movement of the filter is independent of the wire, which prevents the filter from moving while you're doing complex, interventions with atherectomy, so on and so forth. Give me a little there. Oh, I'm sure they have. Absolutely. And we firmly believe that should become part of peripheral intervention. Unfortunately, it has not yet become part of peripheral intervention. So there I've put it in the posterior tibial artery. Now I'm protecting it all the way down to the foot. That's good. That's good. Now we're going to walk it back. We're going to do a quick filter and then a quick IVUS.
Can we get an
Okay.
018 IVUS?
Okay. So let's get the filter down. So the embouchure, like I said, this part of the wire has the tiger stripes. You can see black and white. So this way you know that you're on the right part and the filter won't go flying distal. The beauty of this is as you're doing these lesions, you don't have to worry so much about the filter moving and causing dissection. The disadvantage of this filter is that the capacity of the filter is less than the spider. So if you're expecting large volume of thrombus or debris to come down, this may not be the filter to use. But the beauty of the filter is that it's independent of the wire. Floor, please. And because it's independent of the wire, you're able to move bulky devices back and forth without a problem. So I'm going to deploy it right about there, and it's very simple. It's just pull off the red tag and deploy the filter. So there's the filter. We're just going to bring it back. Now we're going to do a quick IVUS. And the IVUS is getting ready. You basically can throw this part of the filter away because you have a separate retrieval device. We don't have an IVUS set up? Oh, I thought we had an IVUS set up. I thought we had an IVUS set up. Okay. All right. All right. So we have an 018 Phillips IVUS. And the reason we do these IVUSs, again, is to look at the morphology of the lesion to help plan our sizing as well as our atherectomy device, whether there's a heavy calcium that may mitigate whether we need a shock wave or some sort of calcium management device. We also do IVUS. IVUS has been shown in our personal data from Sinai with over 500 patients that in mal-deployed stents, especially the biomimetic stents with Supera, IVUS sizing definitely seems to help with the outcomes of Supera stenting. So clearly, there is a good role for IVUS in endovascular, although the outcomes have not really been studied. There's been one study in JACC that said in DCB the outcomes may be better. But again, it's a randomized control study, so out of Australia, so very good data. But however, there's a lot of criticism to that study for many reasons, which I'm not going to go over at this stage. Okay, let's go live, guys, with the IVUS. So I'm starting with IVUS in the popliteal. So start recording, please. Okay, so you can see as you see the IVUS, it's a good sized lumen. I'm just pulling back slowly. And as I'm pulling back slowly, you can see there's not much thrombus there. And then you can see a lot of soft plaque. And then you can see there's the area of occlusion with what looks like soft plaque and pretty much occluded around the catheter. You've got to think there's underlying thrombus there at some area. And then you can see the different areas of stenosis. And as I pull back, you'll see again a calcified lesion, very tight. And then really pretty clean up to you get to the prox. There's some floating debris, likely thrombus at this area, and very tight in that area, likely thrombus again. Very speckled in appearance. This is fibrocalcific plaque. Okay, and then so you have fibrocalcific plaque mixed with thrombus with there's again, see that speckle and see how it's moving with the vessel? So that's layered thrombus for sure. And that's part of the reason why the embolization occurs. You can see it there. And that's part of the reason. You can see the long set. Look at that. Look at the level of speckled thrombus there. Liz, can you talk to him, please? No. 1 second, sir. And then you can see here, good flow, and then the lumen all the way up to the top. So because of our clinical suspicion, his flow dynamics in the vessel, and also the fact that we have an IVUS that's very suggestive of layered thrombus, we're going to go ahead and run a newer thrombectomy catheter. It's called the Jedi. The Jedi is basically a mechanical lavage thrombectomy, I would say. It produces a jet that comes out at the tip of the catheter and then goes ahead and goes ahead and also does aspiration at the same time. So we're going to run this through. Why not put the filter after IVUS? Because I guess with IVUS can also embolize. It is a bulky catheter like any catheter could be. So the filter protects any sort of embolization from occurring. But I don't think there's anything wrong with putting the filter after IVUS either. So we're just going to go down. And at this stage, we feel that we can do any sort of intervention here, whether it's balloon angioplasty, spot stenting, or do focal, atherectomy, followed by stenting. Okay, turn it on, please. So we're just going to do this slow aspiration of the lesion. Let it do work. It doesn't aspirate straight blood, and because of that, you're going to have. It's going to look like you have a lot of blood inside the container. It's about 2/3 to 1/3, I guess, like saline to blood. So therefore, it's really the technique of aspiration that's very, very important. So you can see here we're going very, very slow and allowing the catheter to do the work and really allowing the catheter to suck all the thrombus out. I know I have some occluded segments, which I'm really not trying to push through, but I'm not trying to let the catheter kind of work its way through, which it's trying to do. But in this area, it's not. So I'm just going to let it sit. There it goes. So I'm just going to let it sit here and let it just aspirate as we go down. It's lavaging and aspirating the vessel. And then as you can see, I'm just going to try to take it through the occlusion and see whether we can easily aspirate the vessel and make it look really, really pretty. And remember, we said it was by the C of the CSI that the occlusion really starts. And you can see very, very soft plaque with overlying thrombus, which may or may not be able to work here. And we're able to pop through it. Okay, now I'm going to let Dr. Ali just walk it back.
Leave it on?
Yep, you can just walk it back with it on. Yep. This is to save, right? Okay. So now that we've done an aspiration thrombectomy, because of this, we're going to go ahead and do a DSA. A little more. Yep, you're out. Off. Okay, ready for DSA? Are we on DSA? Inject. So now we're going to inject and see what the flow looks like. And look at that, guys. See, the flow is better now through the SFA and not through the profunda.
Without a single balloon.
And you can see here now, you've actually been able to inject. We've actually been able to clean out the majority of the underlying. See, look at that. So even though the SFA has significant lesions, you've been able to aspirate out all the clot and all the debris that was slowing it down, and you can see the before and after picture. Let's get the device. Open the Hawk, please. Hawk?
Hawk M.
Hawk X. Hawk
M.
What's that? What's the question? The jet stream? Yeah, definitely. The aspiration occurs all the time, but the catheter is most effective when you're going antegrade with the aspiration. So yeah, the answer is you can aspirate when you're coming back as well. And that's the situation. Looks really good, right? Yeah, we're done. What's that? Can you aspirate under low pressure? Well, they missed the filter placement. They joined the party late. The filter is already in. So anyway, so now we decided to do a directional atherectomy, which we're doing. So, and I want everybody to see the flow difference in the vessel. You know, the difference in the vessel shows, again, how the utilization of intravascular ultrasound can help you to prevent complication and to choose the device. So obviously we know that it's a long segment occlusion. And what was our reference vessel diameter, guys? 6. It's a 6, so we're going with a Hawk M, which is aggressive. And I'm only going to cut the areas that are occluded. I'm really not going to go crazy here. And I know it's occluded. We'll do a little roadmap there since my glow tape is off the the body here. So I'm just going to center it. Let's do a little quick roadmap. Okay, ready? And for those of you who are from the beginning, you see how the flow is so different now compared to before. You know, the flow is much, much better. So we're just going to cut from the first lesion down. This is not vessel beautification. So I'm not too concerned about making this vessel look gorgeous, because we know that the longer, more lesions I touch, the likelihood of the more my restenosis is going to be. So now I'm going to go in and I'm going to start at that area. I'm just going to do a single 2-quadrant cut initially, and then decide if I need to do a 4-quadrant cut. So I'm coming down. I'm just going to pick the quadrant I want to cut. Okay, I'm cutting medially here. Turn it on, please. So I'm just going very slow. Off. I'm going to stay in that quadrant. I'm going to come down to here. On, please. Off. And then I'm going to go down distal past the CSI. I'm going to go right about here. It's okay.
Come off roadmap.
On, please. Stay there. Oh, okay, it's okay. Off. So I'm going to come back up again. I'm going to have to repeat my roadmap since we moved here. And then I'm going to go with the lateral cut. Uh-huh. Uh-huh. Flow is already better. So I may do a lateral cut here on the proximal. So Ibrahim is going to rotate it laterally, which is exactly opposite of where we started, which I think should be right there. Okay, on. Again, a very short focal cut here. Off. And then I want to cut over here. Okay, on. You can tell by the change in the off. On again. Whoops, I'm lateral. Yep, I'm still lateral. On, please.
1 second, it's not packing.
It's not locked. Uh-huh. There you
go.
On. You can tell by the change in the cutter that I'm engaged. Off, please. And then down below. On, please. Off. Well, I think the penumbra sucks the same as these catheters. The penumbra's mechanism of action is totally different. Penumbra is a pure suction catheter, while these catheters do both lavage and suction. We're going to clean that out in a second to show you what we got. And now I'm just going to do a quick IVUS to decide what we're going to do here. From what? From the lesions such as this? It depends on what trial you like. I mean, if you believe in impact long, then the TLR rates will be at 3 years in the 70%. It's still greater than a 25 centimeter lesion. So it totally depends on what lesion. This has not really been studied in any randomized control fashion for us to judge what TLR will be taken here. So I'm going to go ahead and run a quick IVUS, and then we're going to decide. I know Dr. Ali, you had talked to me about doing a DCB and necessarily spot stenting. So we'll figure that out with this right now. So we are going to go. Remember the impact long registry. There was a 40% spot stent rate in those lesions, and the TLR rates were low for 25 centimeter lesions. So therefore, it does seem to work. We do know that from our data and from the data that Medtronic provided us, helped us with in the sense of looking at the analysis of the impact, the series of study. The major reason for failure of DCB seems to be recoil. So we really may need to stent those recoil, and maybe directional atherectomy and good vessel prep will help. So here goes the catheter. We're going to do a quick IVUS back. So again, starting distal to proximal. On, please. So record. So I'm just pulling back here the IVUS, and you can see here, very good resolution, good lumens, about a 5 to 6 millimeter lumen. And again, that's the occluded segment, a little bit of dissection there. But you can see that the lumen has gotten much bigger with our atherectomy device. Clearly, probably can do more cuts here. But clearly, I think with the two lumen cut, we've done a pretty good job. So it looks like really going to have to cover this whole segment. It looks pretty diffuse in this area. It's not like you can leave one particular area. So I'm going to try to go from healthy to healthy. So all this, yep, we've got lesions over there as well. And I think it's around 10. Right over here is probably the healthiest segment. So this is around 8. All right, what's the longest impact balloon we have in a 6 millimeter, guys?
You want an 018 system?
We have an 018 long impact.
Then it's going to be 150.
Do we have a 200 impact or no?
We have a 156 018.
150.
We have a Ranger 200.
Oh, give me the
018.
Ranger 200 then. Give me the Ranger 200. So yeah, well, you know, part of we have the Ranger 200. So part of what we do is, you know, these balloons by Medtronic, they're great balloons, but unfortunately, do we have the longer lens? 250 is but it's going to go through a 6 French though. We're in a 6 French system. Yeah, but it's going to be very tight coming out, no?
So
Or will
035.
it come out?
It'll come
All
out,
right,
but it's
then
just
give us that.
035.
That's
as long
even
as it
better.
tracks. Yeah.
So the problem is the Ranger has the 018 system, sort of Lutonics. However, Impact doesn't have it. And so therefore it becomes very cumbersome to do this with a 6 French system and pull it out. So we're going to use it. Let's hopefully it passes. I'm taking bets from the audience. Please send me your text on how many of you think it won't cross, because I am here to say that it won't cross.
It will cross.
I may be wrong. Let's
It
see.
will cross.
Pretty tight. Let's see. Let's see.
It will cross.
The pressure's on, Medtronic. The pressure's on. So we're going to go ahead and load this up. Hold on. All right. Go ahead. Mm-hmm. Pressure's on. Audience response is saying what? Will cross, won't cross, Liz? Radio silence. My goodness. Audience is right. It's crossed. Look at that. All right, we'll start from here. Yep. To there. All right, a little longer than we expected, but should be okay. I'll go a little bit deeper. Okay, right there. All right, very good. So impact balloon worked very well. And now we're going to go up with the balloon. So we're going to leave it up for about 3 minutes. Watch the balloon inflation. You can see the lesions are quite tight in certain areas. So vessel prep with balloon in DCB balloon angioplasty was done in Europe, was not done in the American IDE. Yes, just breathe it out. Breathe it out for us. So it's going to hurt a little bit as we're opening it. Keep opening. Keep opening. So we just keep going up to
Nominal
is what?
5.
6. Okay. Not quite 6. Okay. And that's your 6 atmospheres right there. There you go. There you go. So we're going to leave that up. So any questions from the audience, Liz, as we let the drug do its work? So you can see it's a very robust sizing of this particular vessel, and hopefully this will work. So about two and a half to 3 minutes of this balloon, and then we'll take a picture and we'll decide what we're going to do. There's a little bit of recoil around 15, so possibly that's the spot where we're going to have to put a Supera to be able to prop it open. Is he bratty or is it my imagination? So one of the things you have to watch for is obviously vagal bradycardia. So in this situation, there is, no vagal bradycardia. So that's good. No, 1.5 minutes. No. 1 minute, 20 seconds. That's only.
Mm-hmm.
So we'd always go to 3 minutes here to allow the drug to elute from the balloon into the tissue, and hopefully to prevent any prevent any restenosis. I don't see any 30% recoil here so far. The balloon's pretty well expanded. Maybe a little bit of a recoil at the level of around 14 or 13. Let's
Probably
see.
5.5, and then we'll
Probably a
probably need a
5.5, yeah.
6.0 Dorado or something. This is the stuff you pulled out.
All right, down. So we're gonna let it come down at 3 minutes. Probably gonna have to go double negative twice. Double negative. So with this large 035 Medtronic balloon, you really have to go down, really make sure it's deflated before you do anything, and really have to wait till the bubbles really stop moving. What we tend to do is look distal before we go and pull it out by looking here, so our filter doesn't move. Go ahead. So, and we don't want the wire to come back. And I usually will assist Dr. Ibrahim by pulling on the balloon at the level of the sheath to prevent the sheath from also infolding, which can occur with these very large balloons. You know, so it's almost out. And notice we didn't touch our inflation device to also make sure that it stays negative as we come. So now we're just going to take some pictures and then decide what we want to do. So I want to keep an eye on the filter. Well, certainly our flow pattern has changed, you know, so we definitely have better flow in the SFA than we do in the profunda, which is a good sign. There seems to be a little dissection distal, no, right? No, a little bit,
Maybe a
right
little
by
bit.
CSI, which we
Yeah.
thought there may be. And then let's see up top here. That certainly looks good.
Small.
I mean, you could argue to leave that dissection alone and maybe stent just the distal,
Just
huh?
the distal one.
Yeah,
Yeah.
we're just going to stent the distal dissection. Give us a 5.5, 60 Supera, please.
You want to take a 6.0 Dorado first?
60 Supera and a 6.0 Dorado, please.
6.040 Dorado.
6040 Dorado. So now I guess the question comes is whether we should take care of the outflow. Unfortunately, there's no real data to take care of the outflow. It would make logical sense. One of our good friends, Dr. Marianne Grodman, really believes that we got to fix the outflow at the time of the SFA to maintain patency.
Dorado
you know,
first. Dorado first. 6.0 Dorado.
with the lack of data, I think it's very difficult for us to go ahead and fix it. And I'll just take another picture of the distal runoff just to show you. Ready? Inject. So in the meantime, what I want to do is just take a picture of the filter, make sure the filter is not full. You can see the flow is very bad in this right now. And the question is it because the filter is obstructing in the lesion? Yeah, the filter is obstructing the lesion. And you can see that lesion is very, very tight. So the issue here is, do you balloon it? Well, you have high restenosis rates. I mean, do you put a DES? Do you do you do atherectomy balloon? And I think at this stage we don't have enough data to suggest what to do. So I mean, I'm probably going to get criticized for this. Let's retrieve the filter, but I don't think I'm going to do anything here. If I was to do something at this stage, if I had a bioabsorbable stent, I think this is an ideal case for a bioabsorbable stent. Put it there, you know, take care of the lesion and prevent it from occluding. If this does occlude, then it does jeopardize my thing. So I'm going to wait for the audience to tell me what they think I should do. Any responses, Liz, on what they think I should do? Okay, nobody's responding. Nobody's helping us out here, Ibrahim. So I think you and I are going to have to decide what to do.
I don't know. My opinion is to fix it.
Fix it? Okay.
Only because we're putting a stent in, and
Right.
the last thing I
So you
want
might
to
as well
see
just
is
do
the
a
stent
DS
go
there?
down, and I would feel better sending the patient home with a good outflow.
Okay.
And it'll be a very, very focal
So what would you
balloon.
fix it with?
I would just balloon it, no
You just
stent.
balloon it?
Try your best
Or
not to
do a
stent it,
serenader maybe?
even if you need to undersize the balloon just to open up
You
that
want to
little
do a
tight
quick
lesion.
serenader for that?
Yeah, I think so.
Okay. We did, yeah. Oh, well, we didn't talk about it, but maybe Ibrahim can talk about how important vessel prep is, Ibrahim.
Yeah, so the Supera
Oh,
delivery
boy.
system is the nitinol wires that are woven together, and once you deploy it, it's pretty much deployed. There's no real post dilating it. And the radial force is quite excellent. So you want it to deploy nominally. So the only way to really get it to deploy nominally with the proper radial strength and no compression and no elongation is to really, really prep the vessel well. So when you're deploying the stent, it's almost like you're deploying it outside the body. It just deploys as it's made.
Uh-huh. All right, I guess, but that's not telling me the data says what. All right, so give me a new wire. Give me
You want
a
a command?
wire. We have a command, don't we?
No.
So people may say, well, why'd you lose the wire? Well, honestly, I think I can rewire this without a problem. I hope I'm right.
Never mind,
If
Kenley.
not,
We got it.
we'll look bad on camera, but we should be okay here. So you're saying leave it, huh?
What's
Okay.
the reason to fix it? Just because we did
The
work?
reason to fix it is to try to keep the patency, I guess.
Yeah, that would be.
Well, we don't have any data that suggests it
No.
helps, but it would make intuitive sense, right? And also, if this closes, then it's going to reduce our patency for sure. So let's. I mean, we'll see. So maybe we do a chocolate balloon or a serenader. What do you think we should do?
I think a serenader would be fine
You want to do
here.
a serenader here,
Come short and
or just a
40.
regular balloon? I mean, there's.
Yeah, regular balloon would be
regular
fine
balloon.
too. There's.
You know. All right, that's fine. Perineal is fine. Okay, we got it in the perineal. Okay, so let's get a serenader. 3-0 short.
3040.
The roadmap. So ready.
Mm-hmm.
Here. So maybe you can talk about the mechanism of how this balloon works and how you're supposed to use it, Ibrahim.
Yeah, so it has little blades on it, almost like a Wolverine balloon for the coronaries. It has 3 blades around it, and we inflate it to an atmosphere of 4 to bring out the blades and not fully inflate the balloon, and that just gives a little bit of serenation, so to speak, to the vessel. And then when we inflate it all the way to 6, which is its nominal pressure, then it expands out the vessel. And the thought is by creating those serenations, you dissect the vessel somewhat less by getting a nice equal expansion of the vessel.
Okay.
It only comes in for the tibials, though, unfortunately, right now. So really, our
The 5-0
experience,
vessel, 5-0 serenader.
yeah. So our experience has been mostly in the tibials, but I think it's been pretty good. Right there.
I'm across it there. I'm gonna come back a little bit.
Yep.
Okay. Good. A little more right there. Okay. So we're just gonna show you how this works. One second, sir. So So we're going to go up
So
here.
going up to a pressure of 4 first, just to engage the blades. And I'm at 4. We stay up for a minute,
So we
allow the
keep it up
blades
at
to do
4
their work.
atmospheres for a minute. So you see, this is why peripheral interventions take a long time, because we wait a lot. Okay, that's a minute.
And then we're going to go up to 6 to fully inflate the balloon. Up at 6 now.
So that's six atmospheres. Okay, down. Is that enough, or you wait another
I'm
minute?
only going to get 50. Pressure's low.
Okay. Down. Just gonna walk this back now. Mm-hmm.
Mm-hmm.
It's certainly much better flow, right?
Believe it.
That we're happy with. Now we can. So we're definitely happy with that. So now we're just gonna go ahead and take care of this with a quick Sapera. Could argue to leave it, but I think we should send it. It's pretty complex, around 30. All right, so we're gonna go with a Dorado, and then we're gonna balloon it, and then we're gonna go with a Sapera, and we'll be done in a sec. So now I've got a command wire down, and I'm just gonna go with a Dorado, and then we're gonna just balloon across CSI, and then we're just gonna put a Sapera there. I think we'll be done in a second. I kind of feel better that I listened to Ibrahim, because now I know I've got good outflow, even though I don't have the data to support it, but it makes intuitive sense. So there's a good balloon. It's called a Dorado. Very strong, capable balloon of being able to be inflating. Okay.
Made of Kevlar, right?
It's made of Kevlar, exactly. Go up. 12, 14. So really open it up. We go high pressure down. Go up here. 20. Okay, down. Good. Okay, now that it's down, we're just gonna walk it out. Get the Sapera ready, please.
Yes, sir. And a 5.56.
Can I
That's
take
fine.
a picture first?
Mm-hmm. 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 So again, we prepped the vessel for Sapera. Let's go ahead and let's do a quick roadmap, like you said. So flush the Sapera always, both lumens, and then wipe the Sapera down nicely. See, there you go. So all the way across 30, we're gonna go ahead and Sapera it. Always want to wipe the lumen down.
I got wire here.
Oh, let me just find the sheet here.
Mm-hmm.
Okay. Mm-hmm. Okay, go ahead, Ibrahim, deploy it. So while Ibrahim deploys it, obviously slow throws, and really sort of, be judicious. Have, a dry gauze in one hand, a wet gauze in the other hand, whatever you want, and then go ahead and just deploy it. Because once you deploy it, there's really no coming back to make it look better. There you go. That's pretty good. So you can see that the distal end is going to come out slowly, and Ibrahim is just going to allow it to flare. Just going to allow it to flare just around there. Yep, you're going to allow it to flare. There you go. Very nice. Very nice, slow, disciplined throws. Prevent the stent from expanding, from elongating. Although we know from our data using DCB as provessel prep will reduce the restenosis if this stent does elongate. So I feel a little bit better knowing that I've given everything I can. And that too, the data was with Impact DCB. So we use the right DCB to go ahead and prevent any hopefully TLR rates will not be. Uh, well, we'll probably do it offline, but because, we've already exhausted our hour. So we're just going to go deploy the Supera and then take a picture and then do an IVUS, make sure that everything looks good. And if everything looks good, we're all done. What would we do extra if there was a lot of you got to come across the CFCSI, okay? So if there's a lot of recoil in the proximal aspect, we may put another focal Supera. I think the Supera is such a great stent, has so much data associated with it. It just need to be deployed properly with the proper vessel prep, and you tend to do really, really well with this stent. So this is like they say in cricket, this is copybook stuff. He's doing it beautifully. Probably foreshortening a little bit, which I think is reasonable because it's an area here, and you can see how Superb brings the wire back, which we're not concerned with here. The wire is coming back, but we're fine with that. Just want to land it at the top of the CFCSI, which we will, without a question. So he can use his left hand to elongate if he wants, or pull it back. He's stacking quite a bit, but over time, this will basically become a normal Supera, well deployed Supera. It'll sort of smooth itself out, for lack of a better word, and I think everything will be good. And there's the lesion right on top of the CFCSI, and he's just going to deploy it now. So it's 10, 20, 30, 40, 50, 60. It's a perfect deployment. Perfect. Good. So we're going to just walk this out. He's going to lock it, Flora, please. I'm just going to keep the wire in the stent because I don't really, distally, I'm not too concerned. And then we'll just finish with 2 pictures. And then we'll do the IVUS, like I said, offline. So we'll start with the picture of the foot. Okay. Okay. Get that thing out of the way here. Okay, DSA. Okay. Very good. Mm-hmm. In terms of patency, Silver has randomized control data associated with it. Supera obviously doesn't. So definitely, I think in these lesions, Silver, has been studied. Well, Supera has been studied in registry form. But I think you use Supera and Silver for 2 separate reasons. I think Supera is used for areas of crush, while Silver will be used to prevent restenosis. I think Supera, when deployed properly, is a very effective device, and you can see the flow is fantastic. So I think we're done here, and we're going to IVUS at the end and then take it from there. Going to take another balloon angioplasty here just so everybody can see how everything looks, and then we're done. So that area right there, we'll probably have to stent after doing an IVUS, and we'll take a look and we'll decide. So with that, we're going to sign off here in New York. I hope that was helpful to you. Thank you again. I really appreciate you allowing us to be part of your education, and we'll see you next time. Bye-bye. Thank you.